You're listening to the Cancer Assist podcast, hosted by Dr. Bill Evans and brought to you by the Cancer Assistance Program. Wherever you are in your experience, we're here to provide help and hope as you navigate cancer prevention, treatment, and care. Help when you really need it.
Well, welcome to the Cancer Assist podcast. And for those of you who are repeat listeners, I think you're really going to find the current episode really very interesting, because we're going to be talking to Laura Jin, who's a child life specialist working at the Juravinski Cancer Centre. And we did do a previous conversation about talking to children with cancer with a child life specialist, and you could go to our podcasts that are all on the Cancer Assistance Program's website and listen to that. But the slant on this one with Laura is going to be quite different, because she works at the Juravinski Cancer Centre, and she works with the children of parents who are receiving care there. And that's quite different than what we talked to Bridget Veltri about on our previous podcast. So welcome. It's good to have you here. Thank you for coming in to do this podcast. It's such an interesting area to work, and many people would say working with kids whose parents have cancer must be very difficult. So I'm interested how you got to this position. Like, what was your background? How did you kind of evolve into this position of a child life specialist working at the Juravinski?
Yeah, well, thanks so much for having me, Bill. I'm really excited to be here. And like many people know, or maybe not know, child life is a growing profession. So it's always nice to be able to share more information about it whenever possible. I actually came into child life in a more roundabout way. So I started, my first master's degree was actually in cognitive psychology. I had a background in undergrad in mental health, and at the time I thought I wanted to do research and teaching. So I spent a few years after my master's working in pediatric oncology, so children who have cancer diagnoses, and I helped manage some of their clinical trials. So I learned a lot about cancer, came to appreciate the complexities of illness and diagnoses and managing that with children. And then at the same time, I also started teaching part-time at McMaster University. So I still do teach there 1 day a week. I'm part of their sessional faculty in the Department of Psychology, Neuroscience, and Behavior. And throughout this time, a lot of my course work was on pediatric mental health, in particular, like the disorders of the DSM, like anxiety, depression, childhood schizophrenia.
DSM? Find that for me as an oncologist.
The Diagnostic and Statistical Manual in terms of mental disorders. So that really kind of bounced off of my undergrad in terms of mental health care. And then I began specializing in, again, pediatrics through my teaching career. And I did that for a few years, and I realized, while I love children, I love development, I love thinking about physical and mental health, it was not enough to be behind the scenes. I really wanted to be on the front lines. So hence this career shift into child life. So I went back to school. I have a second master's degree now. And what's amazing about the child life specialist degree is that people can come from a variety of different backgrounds. You can come from psychology, biology even, but the core of it is that you become experts in a sense of developmental psychology, and in particular, being able to apply that to the healthcare setting. So we're not mental health clinicians, we're not, therapists or social workers per se, but we have similar training in how to help children cope with difficult situations. Now, having that career shift is where I started realizing, there are so many ways that my old skill set can still apply to this new career. Hence why I was so excited when this opportunity at the Juravinski came up. The vast majority of child life specialists in Canada work in pediatric hospitals. So for instance, Mac Children's, Sick Kids, London Health Sciences. These are places where the majority of child life specialists are, who help children who are the patients. But it's a growing field, and it's one that I'm very excited to talk about today in supporting children who have family members with illness. Because for a long time, I think we focused on just the kids and how that influences their, again, healthcare and mental health and the family system. But we're also starting to realize now, and there's more literature in this area, about how children also need to be walked through or help coped through their parents' diagnosis, right? So in the context of something like cancer, you see I've kind of looped back into the field of oncology. And now I'm thrilled to work here every day. And I still teach part-time, so it gives me the chance to still connect to students and advocate in the field while working with patients directly.
Wow, it's quite the journey you've taken to get to
Yeah,
where you are.
it's
Now,
quite
you mentioned a
roundabout.
couple of times it's a growing field, and I got that impression in a very superficial bit of reading I did about child life specialists. And why is that? Why is it a growing field now? Why are we just coming to a realization that there's a need for something called a child life specialist?
That's a great question. It's a few different factors, I think. Child life has actually been around for longer than people might think, about 100 years at this point.
Oh, really?
It started in the States, and that's where the majority, I think 90% of the world's child life specialists actually are in the US. Canada right now has about 600, so it's a very small field. So part of it is the kind of need for recognition within the healthcare setting about not only mental health care in general, which as we know has been growing in the last few decades, but also realizing that children have unique needs from adults. I think a lot of that came with the better research that came from developmental psychology, realizing that kids at different ages need and think about the world in different ways. And a lot of that has helped propel things like child life to the front lines. And even right now, it's a great time to enter the field because it is growing and more hospitals are becoming on board. This role at the Juravinski only existed less than 5 years ago. And recently, we also expanded our system into Hamilton General Hospital to support the adult ICU there. So again, it is growing, and I think it's one of those professions where as soon as you tell people what you do, people see the benefit of it. But it's just right now like helping people, again, understand the importance of providing for children in a developmentally appropriate way.
Now, you're working in a cancer center. Now, how many of Ontario's 14 cancer centers would have a child life specialist? Do you know? Is it all of them or just a few? Or
It's a good question. I think because the Child Life Network is so small, we do a good job of trying to keep up with each other and where we work. I know a few of the Southern Ontario centers have child life specialists who at least work part-time. The challenge, however, is when you're funded by a pediatric center, there's lots of money and donations that go towards pediatrics, right? Mac Children's receives a lot of funding from places and charities all across Ontario. When it comes to adult healthcare, and we don't need to get into the politics of it in this podcast, but it's harder to find funding for roles like this that are more focused on the psychosocial side. So some of the bigger cancer centers do have a child life specialist. And in particular, for instance, Sunnybrook Hospital, their PYNK program, PYNK, for people with breast cancer, they have a child life specialist who works with their team. So it is growing. We're trying to get more child life into adult hospitals, not only for cancer, but in places like ICUs, intensive care units, and even adult hospice or palliative care. And with the hopes of podcasts like these helping spread awareness and therefore more funding, and hopefully in time you'll have child life specialists in every health center.
I can certainly see how this could be growing in another sense too, or the need growing. We're finding just in cancer incidence that the age of diagnosis is becoming younger and younger. Reasons for it, things like our sedentary lifestyle or obesity and some of our other lifestyle habits that are leading to cancer at an earlier diagnosis when people are, their children are young and could be just recently born or they're in their early teens and so on. It's much more common, I would think, and will become increasingly common given the trends we're seeing in cancer incidence. So your job may be getting bigger. And I do get the understanding that, a child's perception of a parent's illness will certainly differ depending on the age they are at. And maybe you can talk about that because clearly there are times when children are, preteens or younger, when mom's got breast cancer and maybe very sick and understanding why mom's losing her hair or not able to do the things and care for them the way they were previously when she was healthy. How do you work with a child to help them understand that and to accept the change that they're seeing in their parents' behavior, appearance, and so on?
It's a really good question, and it makes up, I would say, like 30% of the work that I do with families. Whenever we talk about how people understand illness, for instance, I break it down into 4 kind of age groups / developmental groups. So the first is 0 to 2. So we have like infants and toddlers. And if you can imagine, they have very little conceptualization of illness. At that point, if, they've seen mom have a cold or, dad have a broken bone, for instance, they might have a basic understanding of what it means to be sick versus healthy. And in that case, I often advise parents to use the word sick, but to describe it as a big sickness. And that's a very like infant and toddler friendly way to conceptualize that this type of sick is different than the type of sick that's easy to make better, like a cough or a cold. With this age group, beyond that understanding, the thing that they are most worried about and the thing that can cause the most distress is separation. And when we think about, the importance of attachment and secure attachment to a caregiver, oftentimes it's prolonged hospitalizations, treatments that require parents to be away from home, especially if you don't live near a cancer center and you have, parents having to live in separate cities for a little while, right? Those are the things that are going to be most impactful to children at that age. So what I often say to families is to help kind of ease some of that burden is to really focus on the attachment piece and ways to facilitate connection despite that distance. There are many strategies that we could talk further about, but one of the quick ones that I do is called connection stuffies. And you don't have to have a child life specialist.
Stuffies? Did I hear that correctly?
Yes, you did.
All right. This is new to me, so I think it's going to be new to a lot of people listening.
So you get any sort of stuffed animal, and the key is to get 2 or more of the same ones. So let's say you have one child. You give one to the child and one to the parent who's going to be away. And you tell them that these stuffed animals are the same. So therefore, they are a bridge, a way to connect the love and connection. And you can do really cool things when parents are in hospital to kind of help with their magical thinking, the child's, I mean. For instance, I might say to families like, if dad's in the hospital, we're going to get your child to give this teddy bear a hug. And then we're going to have dad on the phone and say, oh my goodness, did you just hug the teddy? Because I felt it here at the hospital. I'm going to hug the teddy bear too. And you let me know if you feel it, right? Things like these are really sweet for bridging that connection. And it's an intervention that we often use as child life specialists. But again, you don't have to go through child life. Like you could go to the dollar store and buy 2 of the same stuffed animals and use this as a way to facilitate that connection. And it kind of brings me into the next age group, which is preschool, so 3 to 5. With this age group, connection and attachment are still a big priority for them. However, instead of viewing it as being separated, they are more concerned about a change in routine. So we still have a very basic understanding of illness. And again, we can use the words like sick versus healthy. We can talk about it in terms of a big sickness that's hard to make better. And depending on how, I would say, like mature that child is, I usually advocate for the use of the word cancer. And this is a challenging topic for many families because, as parents, you have this protective nature of wanting to protect your child from such a hard, difficult word. But we have to remember that with children, especially at that age, they're learning so much about the world, and learning, and especially language and being able to put language to things, gives them autonomy, gives them a sense of control, and helps with coping. So earlier I talked about those, connection teddies, right? That can still be a tool to help this preschool age group. But I would also encourage parents to be a little bit more upfront about what their illness is called. When we think about providing care for preschool ages in particular, we often refer to the 4 C's, and this is something that I talk a lot about with families. So one is called, so we name it, we call it cancer. We talk about care, so we reassure that child that even though I have this sickness, I still will care for you. Mom and dad will still care for you. We still love you. So that's the second C. We talk about cause. And in this case, we don't need to get into like, the genetic markers of what causes cancer, but more so what children need to know at this age and what they need to feel reassured is that they did nothing wrong to cause this. Preschool age children really think about the world in cause and effect in terms of their own bodies, their own abilities, their own actions. And a very common misconception you see for this age, again, 3 to 5-year-olds, is that they think they did something or they didn't do something.
They made mommy sick.
Exactly, right. And it's almost never something that the parents said or, did to imply this, but it's just how children that age think about things, right? It's just a common misconception. One that I saw the other day, and I spoke to a family about, their little 5-year-old thought that their mom had cancer because he didn't wash his hands enough. So he became really stressed about hand washing. And then when we started kind of going into it and talking about it, we realized there was this misconception, right? This cause and effect that he kind of bridged in his head.
Isn't that interesting? I had no idea.
Yeah.
It's really important to understand that for families with children at that age.
Yeah, absolutely, right? And again, it shows the importance of having someone with a developmental psych background, because this information is available online, but I would say it's hard for parents to filter through. A lot of it is in the form of research and literature right now, which is not accessible for every family. And it takes someone like a child life specialist to become that translator, right? To meet with the families, to look at the age of the child and where they're at developmentally and say, here are the common questions and misconceptions that child might have. Going backwards, I realized I only said 3 of the 4 C's.
Okay, we'll do number 4 now.
Yeah. So there's what's it called? That you still will care for them. So care. There's cause. So reassuring that it's not the child's fault. And then the last one is catch in terms of contagiousness. So you need to reassure children that it's not something you can catch from other people. So it's not like a cough or a cold where, mom or dad sneezes and you're going to get cancer. We're reassuring them that it's kind of related to the cause part, right? They can't do anything to catch this cancer from mom or dad. They also didn't do anything to cause this cancer, right?
It's interesting because some adults even worry that it's contagious. And in a workplace, a person who's had a diagnosis of cancer or has a diagnosis of cancer comes back and other people sort of keep their distance because they're afraid of catching it. So that belief's out there. It's not just children. And that's a belief we need to expunge because it's just plain wrong. So there's those things. And there's the language you use with children also changes, I gather, again, with this stage of development, and particularly if it's really grave illness, hospice situation, so person dying. So explaining that to a toddler must be very, very difficult. 2 to 5 is probably something different language, or maybe trying to name what's really happening as it is rather than trying to make something up. But what do you actually do there before I babble on and say things that are wrong?
Yeah. It's so challenging, right? And even as adults, to tell another adult that somebody is dying, that's such a tricky emotional conversation, right? Let alone thinking about it from a developmental lens. When we think, and kind of going back to those age groups, if you think the infants and toddlers, 0 to 2, because their conceptualization of life and death is just not very advanced, what they can see is that somebody is here in front of them and versus somebody is not here. Oftentimes, they don't really notice that something is wrong or something that's changed until after the person actually passes. And it's something that I like to warn family members about, because they'll notice that their infants, even 3-4-month-old infants, will respond in this way. There is initially a period of protest. And if we go by Bowlby and his attachment theory back in the 1960s, he was the first person to kind of seen this. But there's a predictable pattern, and the first one is always protest. You might have more crying outbursts. You might have a refusal of feeding or eating, a refusal to sleep independently, or regular nighttime awakenings. And this is an indicator that infant or toddler is feeling grief. And again, a lot of times there's no way to really prepare them for it because it's hard for that age group to conceptualize the future or the past, right? It's either here and now or it's not here right now. So oftentimes with parents, I say, you might have to retell them multiple times, and it might be painful and difficult for that parent to have that conversation. But it may require, over and over again every day to remind that infant and toddler where mom or dad is, or grandma and grandpa is, right? And this is a time where I say to families, if you have a religious or spiritual belief that can help anchor where, their family member is, it really helps the child. And families will say to me, like, my child's only 18 months. Like, do we have these conversations, right? Will they notice anything? And absolutely. Everything that we've seen about grief research in young children is that even newborns, like 1-month-old infants, can tell when their caregivers are no longer there. So following this protest phase is when you have the acceptance. And for some infants, this can look like a snap back to normal, everything is fine. Other infants, you may see them actually kind of become a little bit despondent. I don't know if that's the best word to use, but maybe less reactive is kind of the way that I describe it. Maybe all of a sudden you see this infant stop crying as much. Maybe you see them not wanting to play with toys as much. Maybe, the parent smiles, but the infant doesn't always smile back. And again, these are normal infant and toddler reactions to grief, right? And as children progress through the developmental stages, we need to revisit grief and revisit these topics to match their current developmental stage. So let's say a child's parent passes when they're 2 years old. Oftentimes when they hit around 3 and they reach that preschool age, it's almost like their brains kind of overnight develop in a new way. And then they're like, oh my goodness, this thing happened. Wait a minute. It doesn't make sense to me anymore, right? So kind of expanding to that preschool age, there are ways that we can prepare children around ages 3 to 5 for somebody's upcoming death or end of life. And we have to be very, very careful with the language that we use. Earlier, I mentioned how this preschool age, they carry a lot of misconceptions. And a lot of the words that we use to describe death and dying for our own coping as adults actually causes a lot of confusion and creates coping problems for children when we use the same language. A common example that we use as adults is that when somebody is dying or dead, they go to sleep, right? We call it a forever sleep, where they're sleeping for a long time, or they're sleeping and not going to wake up. And again, as adults, I think that's a way as a society we've kind of used the language in a way to help us cope. Right. But with children, especially like 6 and under, it's really, really difficult for them to understand the difference between death sleep and nighttime sleep. Yeah.
Confusing.
Absolutely. Yeah. So then you might have children wondering, okay, well, if I go to sleep, am I going to die? Do you go to sleep and die and then come back to life? Like, what happens, right? So that's an example. Another common one is gone to a better place. Okay, where is this better place? Why can't I go there? When am I going to get to go to this place? Does this place have toys and candy? Like, it sounds pretty fun. I want to go to this place, right? Again, common words that we as adults use, but you don't really think about how children think about it in another way, right?
So what's the best advice then? How do you explain these things to that age group? This is when it gets tough.
It's tough. It's so tough. And it's advice that families do not want to hear, but I advocate for very clear, honest language. To use the words dying and dead and death, even though as adults, sometimes you say those words and it kind of makes your own guards go up, right? I often say to parents to practice using those words and become comfortable using that language. And when you talk about death, again, to make it as concrete and clear as possible for that child. So I often advocate for discussing about the body, because the body is something that children are starting to learn at age 2 and 3, right? They know their body parts. They know kind of what goes on every single day in terms of I need to eat, I need to drink water, I need to breathe air. And these are conversations that we can have to help educate that child about life versus death. So the conversation might look like this. We might say, let's say dad is in the hospital, right? We know that dad has a big sickness called cancer. This big sickness is really hard for us to make it go away. Unfortunately, what we know is that the doctors and nurses have tried very, very hard, but we cannot take daddy's cancer away. What that means is that the cancer is going to make him die. When somebody is dead, their body stops working. It means that their body doesn't need to eat anymore. Their body doesn't need to drink water. Their body doesn't breathe. the body also doesn't feel pain. So when we're alive, our bodies, we do all of those things. We eat and drink and breathe and talk and play. But when someone's dead, their body doesn't do that anymore. And that's a way to kind of enter into this conversation. And then what comes next depends on that child's response, right? With children, we always want to give small snippets of information at a time, wait and see how they process, and then give them more information. You have some children who hear that information and they go, oh, okay, that's fine. And then they go back to playing. That's totally developmentally normal. And sometimes parents will come to me and they'll go like, oh my goodness, like, did my child understand it? Like, are they okay? Are they a psychopath? Like, why aren't they sad that dad is dying, right? But it's because when children process difficult information, and particularly grief, they do something that's so different than what adults do. They do something called puddle jumping. So when adults feel grief, we do wading. So we kind of wade through the grief as if it's a river or a lake. Our feet are always in it. So the grief kind of continuously washes over you. As an adult, you always feel the weight of it. You see the impacts of it. Yes, some days are easier or harder, but it never really leaves you, right? Whereas children, they puddle jump in and out of grief. So sometimes they're in the grief, they feel it so deeply, they're asking questions, they're crying, they're anxious, and then seemingly for no reason, they jump out of it. And then they're done. They're playing and laughing and totally normal. And as parents, it can be hard to jump in and out of grief with your child, but I always say follow their lead, right? So if you've had this conversation, you've broken the difficult news, you've used the words dead and dying, and your child is seemingly totally fine, that's probably a developmentally normal way for them to process that grief, right? Whereas on the other hand, if the child then asks a bunch of questions, again, follow their lead, right? I often say, again, if you have some religious or spiritual belief about afterlife and what happens after, use that as an opportunity, right? Mom and dad, we believe in heaven. So even though dad's body is dead and dad's body is not going to be there, dad's spirit and soul is going to be in this place called heaven. And then again, tie in your religious beliefs, right?
This is fascinating and so foreign to an adult oncologist. But who has the conversation you just described? Or do you basically teach the parents to have the conversation with the child, or do you have the conversation with the child, or is it a bit of both? How does this actually happen?
It's dependent on every family. And I would say my default is to always try to empower parents to have the conversations.
I would imagine that would be the case, but
yeah.
I think a lot of parents would find this really hard to do, and perhaps balk at it and want to default to you rather than them taking on trying to have this conversation, which is so difficult with their own child.
Mm-hmm. And, if it's really not possible, there are cases, and I do offer to parents to at least co-facilitate the conversation. I like to have the parents at least present during the conversation to help support whatever emotional reactions come after, right? And in many cases, once I give parents the language, we talk it over a few times, they have a chance to practice saying the words out loud. Many parents feel empowered to have the conversations and then follow up with me after. And then we can say, how did it go? How did your children react? What are some ways that we can help them cope in the long term? But if parents are unwilling, if they're not feeling capable of it because of their own emotional reactions, then it's totally okay to ask a child life specialist. Or in some cases, there may be nurses or social workers who are trained in development and palliative care who can co-facilitate the same conversations. But the root of it is we want to empower parents as much as possible, because at the end of the day, for the rest of that child's life and their development, it's not us as the healthcare workers who will be there, right? As much as I would like to be there, because I love all the families and kids I work with, I can't be there, right? So being able to empower parents to have this conversation, which is probably going to be the most difficult thing they'll ever have to do, then also gives them confidence to support the other stuff, the grief and bereavement stuff that comes after.
Well, this is a very heavy conversation about a very heavy topic. So I think we'll take a break. Maybe it'd be good for our listeners to process what they've heard. I want to come back and talk about a little older age group, the adolescents, and also a little bit about sort of the continuity of care, because as you were mentioning, the puddle jumping and so on, it really requires ongoing supports for the children. And so I wonder just what the role of the child life specialist does in that situation. So we'll come back in a moment. And first, we'll hear a word about the Cancer Assistance Program. We'll be right back.
We'd like to take a moment to thank our generous supporters, the Hutton Family Fund and Banco Creative Studio, who make the Cancer Assist podcast possible. The Cancer Assistance Program is as busy as ever, providing essential support to patients and their families. We remain committed to providing free services for patients in our community, including transportation and equipment loans, personal care and comfort items, parking, and practical education. These services are made possible by the generosity of our donors through one-time gifts, monthly donations, third-party fundraising, corporate sponsorships, and volunteer opportunities. Visit cancerassist.ca to see how you can make a difference in the lives of cancer patients and their families.
Well, we're back with Laura Jin talking about her experiences as a child life specialist working in a cancer environment and the different age groups of children whose parents are ill with cancer and how to communicate with them. And we talked a bit about sort of the toddlers, the 2 to 5 year olds, sort of migrating into those that are a little older. So I guess the teenager or preteens and or adolescents, and then the more adult, and they all have different reactions, don't they, to a parent who's ill and requires a different strategy. So maybe you can take us through those next age groups, how you approach communications with them about dying parents and this sort of thing.
Absolutely. So if we kind of move up throughout the developmental trajectory as we have been, the next we call the school age group, so 6 to 12 roughly. With this age group, we have a much more sophisticated understanding of illness. This is often the group that's curious about treatments, about why this cancer appeared specifically in this person. If it's a thing of genetics, for instance, these are the age groups that's starting to become curious about it, right? And with this sophisticated understanding also comes at the simultaneous moral development that this age group has, which creates challenges with coping. It's a very unique place to be in because these children, again, 6 to 12, they start to understand kind of the causes of cancer as an illness. They understand the different types of cancer and common treatments like chemotherapy, radiation, and surgery. But at the same time with their development, they're very much focused on cause and effect and feelings of justice. With this age group, they're very concerned about what is fair. And when they think about cause and effect, they're trying to understand the world in the consequences are deserved based on whatever action it was. And so it can be very hard for this age group to understand people who have serious illness, especially those who are approaching end of life, for something that they didn't deserve or that they didn't cause.
So right? They see it as unfair that their parent is sick and dying.
Absolutely. And with many children, this comes out through emotional or behavioral outbursts. A lot of times you see a lot of anger, a lot of hostility, resentment, and this could occur towards the well parent or even towards the sick parent. It's just their way of processing and being able to unable to understand why this is happening to somebody who doesn't deserve it. So for instance, I've seen many families where they have an 8-year-old and they've unfortunately broken the news that, mom is at end of life, right? And they've shared that mom is going to hospice, that the doctors and nurses have tried everything in their power, again, to try to get rid of the cancer, but we couldn't. So this is what it means. And oftentimes you'll see children react with hostility, right? They may yell and scream and say, this is not fair, or you need to try harder, or you didn't do a good enough job, right? A lot of kind of anger and blame towards their parents.
Towards the parents or healthcare, doctors?
All of the above, honestly. Sometimes
many directions.
Absolutely. Sometimes even themselves, right? This anger towards themselves might come out, especially in end-of-life situations, if children were not aware that this is kind of the trajectory that things are going. They might have anger towards not knowing the information sooner, not spending enough time with mom or dad when they were well. Some children feel resentment towards their own actions for not being kinder or more helpful back when their parent was at the start of their diagnoses. And if you can imagine, all of these feelings are challenging to reconcile for a 6 to 12-year-old, right? As they kind of figure out the meaning of, cancer, sickness, life and death with their own ideas of cause and effect and the fairness or the justice of the world in which they see it at the time.
It can leave some lasting negative impacts on children, how they view the world subsequently. If they view it as fundamentally unfair that their parent was taken from them, that becomes an ingrained belief. Their whole view and how they live in the world subsequently is going to be different.
Absolutely. And as healthcare providers, I think we need to do a better job of monitoring children for what we call maladaptive grief or maladaptive coping. To a certain extent, some of these things are normal, right? Initial anger, hostility, resentment, outbursts, these are behaviorally normal for this age group, again, as they're processing the information. But what I often say to parents is that, especially after death, if it's like 6, to 8 months and these behaviors have not subsided or they're getting worse, that might be an indicator that this child is struggling to cope in terms of long-term things. In that case, that's when it's maybe warranted to get a mental health professional, like a counselor, a therapist, a school social worker, or a guidance counselor, perhaps, to get on board. But this might require some more active processing of some of the grief experiences. What we know from research is that the majority of children do not enter this maladaptive grief, and that for over 60% of children, 60 to 80 depending on the study, they have this initial period of anger, hostility, resentment, but over time, the family learns to cope, they get through it, they emotionally regulate, and then in the long term, they actually do quite well in terms of coping. Now, again, it's not to say that it's not going to be hard and it's not going to impact them in the long term, because oftentimes children who experience a loss early on in their life do have challenges when it comes to life and death in other contexts, right? They may be children who grow up to be adults who are hesitant or anxious to seek healthcare for themselves. They may be fearful around hospitals. And a lot of these are, again, normal reactions that we see. But I think as a healthcare system, we don't do enough to monitor children for these potential reactions. And so much of this is preventable if we deal with it early on. And that's part of what I try to do as a child life specialist, is to walk families through that end of life in the early grief and bereavement period, to give families strategies for dealing with difficult emotions at home, and to also give them some red flags of potential maladaptive grief that then parents could, reach out to other mental health care providers.
Because that's what I wanted to ask you about, sort of the continuity of the child life specialist working with the child. How long do you stay engaged with them? How do you know when it's time that they're okay, they're going to be all right, or how much monitoring, or do you regularly see them after the passing of a parent, or do you rely on the parent to get in touch with you or others if they see this maladaptive behavior occurring?
Mm-hmm. The scope and timelines vary a little bit depending on where people work. But I would say most people, and myself included, we walk families through the end of life and early grief. So I would say the weeks or a few months following somebody's death. But what we really try to do is, again, empower the families through community resources, through links or, webinars, podcasts, continued education that they can look up on their own time. But I try to stay available to families if and when they need me. But I would say the majority of families that I work with, I will see them, maybe 2 or 3 times after somebody has passed. And that time is really focused on assessing their grief responses so far, looking at potential indicators of that maladaptive grief or maladaptive coping in that child, and then also setting them up with community referrals. Some of the biggest organizations, the most common ones that I set families up with in at least the Southern Ontario area are the Lighthouse, Bob Kemp or Kemp Care Network, and Gilda's Club. And all of these are free organizations, and they host a variety of different programs for kids and teens. Some of them have, grief organizations, some of them are grief organizations that focus more on resources in terms of books, again, podcasts, videos, educational materials. whereas others, Gilda's Club in particular, focuses more on peer support. So there's opportunities for children to meet online with other kids and to do crafts, activities, and to talk about their grief and to kind of feel that support from other kids, which is, very important for this 6 to 12 and also the adolescents, the 12 to 18. So, as much as I would like to be there permanently for these families, again, a big part of it is
pretty
empowerment.
Soon you'd have so many kids to be connecting with, it would be impossible.
Exactly,
so
right? Yeah.
Have we covered all the developmental stages then?
I think the last one is our adolescence. I'll just tack on a little bit because it's similar to how adults deal with grief. And in this case, it's the 12 to 18-year-olds.
12 to 18.
Similar to the 6 to 12, we also see anger, resentment, hostility, and some of those behavioral changes. But what's also common in this age group is that when information is presented, these teens, because of their more sophisticated understanding, more mature cognitive abilities, start thinking about the long term. So I tell parents, don't be surprised if when you drop the news that, mom or dad is dying, the first thing that comes out of this teen's mouth is, well, who's going to be at my graduation? Or who's going to be at my wedding, right? And as parents, these are such difficult conversations and challenging things to think about for yourself. And I always tell parents, you're not doing anything wrong, but these are the things that teens think about, right? They see the wide scale scope and their minds often jump to something far in the future, and that's what they're worried about. So, my advice doesn't really change. I think at the end of the day, it's always being open and honest whenever possible, following your child's lead, but with teens to emotionally prepare yourself for some of those more difficult questions about the what ifs and the future.
So that's challenging enough. What if there's a family and they have kids at different levels? How do you, you got a toddler and you got a pre-adolescent and a teenager, and they're all going through mom or dad's passing. Mm-hmm. How do you deal with it when you've got multiple individuals? It must be an incredible strain on the one parent and others around them. And what's your advice in that situation?
Yeah, I think a big part of it is recognizing the stage that each child is at, gathering advice such as what I provided today and tailoring it to each child. So for instance, let's say you have, a 2, an 8, and a 15-year-old, right? Knowing that 2-year-old is not going to process life or death in the same way, it might require you sitting your 8 and 15-year-old aside, right? Having separate conversations with just them, and then perhaps having an additional one-on-one with your teenager who might have some of those additional long-term questions. So with these families, and part of my job as a child life specialist is to be able to tailor this broad information to each family based on the ages of the children and also their individual coping styles. Sometimes I might advocate for separate conversations depending on the ages of the children. Sometimes parents might even choose to have different timings of conversations, right? For instance, if they have some kids who are older and some who are 2 or 3, the 2 or 3-year-old might not even know that mom or dad is going to die until much closer to the death or even after it's happened. And there's nothing wrong with that if that's what makes the most sense in terms of coping for the family. So again, in terms of the information you provide, in terms of timing about when, and then keeping in mind some of the ways that those different children might respond to it, I think all of these can help a family with, multiple children at different levels kind of cope through it together. But at the end of the day, as much as I'm here and I'm giving this generic advice that's evidence-based, I also recognize every family is very unique. And I tell parents, I'm just here to provide you what works for other families, but your kids best, right? And if you think that they can handle this information or that the information might make them more anxious or not cope as well, you choose when and how to give it, right? I'm just here to support you and to help you meet your goals.
Must be very challenging. I hope never to have to confront that situation. I guess I won't with my age, but it must be also very hard for you. So I'm interested in how you cope, because this is a steady diet of talking to parents and children about life and death and the dying process. And how do you sustain yourself?
It's a great question, Bill. It's something that I'm continuing to work on and figure out for myself. I think a big part of it is social support for myself. So I'm very lucky at the JCC. I have an amazing team of people in the psychosocial oncology team who are always there for a chat or a debrief after a difficult case if I need it. I think because child life specialists are also, well, we know that it's such a small field, we're also very good at connecting and supporting one another. And there's a few of us who work in the realm of grief and bereavement, and we try to meet, once every 2 to 3 weeks to, again, chat through cases and to provide some support. Another part of it is honestly focusing on the part that you can control. And I think maybe this helps all of us cope with, any difficult situation. Is that oftentimes when we think about anxiety or despair or some of these more challenging emotions, they come up because of a situation that we have no control over. And I, as a child life specialist, have no control over the illness of these families. I have no control over treatment, if it's going to work. I am not involved in their medical decisions whatsoever. So there's a lot that I can't actually control. But what helps me cope as a clinician is knowing that what I can do is I can help empower parents. I can provide resources. I can meet with children and help them build skills in terms of emotion regulation and coping. And for me as a clinician, focusing on that piece helps not only with the coping of the challenging conversations, but also helps it feel more rewarding and balanced day to day, right?
I can understand that part. There is an element there that is rewarding because you're really helping people in an extraordinarily difficult circumstance manage it more effectively. I think the vast majority of people listening to this conversation are going to find this entirely new information. It certainly is to me, and I've worked in oncology for 40 years, and I'm glad that there are specialists in child life and who understand the developmental stages and how communication can look very different at different phases and be more effective. And clearly there's a need that I'm glad to see is now being met, probably not as well because there aren't enough of you and people like you to meet all the needs of parents who have children who are confronting the loss of a parent and need to be communicated with in an honest way, as you've mentioned multiple times, this honest, kind of clear but appropriate communication for their level of development. I hope that people who are in this situation listen to this podcast probably several times because I think it's been very rich and in detail. And I just have to thank you for not only the podcast, but for the work you're doing. I see it as very challenging work. And I'm glad that there are the supports that you just described to sustain you, because obviously we need you in the system to do the kind of work you're doing. So thank you so much for being with us and sharing what you do today on our podcast.
Yeah, thank you so much for having me.
Thank you.
Thank you for listening to the Cancer Assist podcast. Find more episodes, resources, and information at cancerassist.ca. or follow the Cancer Assistance Program on Facebook, Twitter, and Instagram. Thanks for listening.